This meeting's being recorded. Good morning and a very warm welcome to everyone to the Health Evidence Review Commission's February 24th, 2025 listening session. Thank you for being here and helping improve care for the Oregon Health Plan members. As I said, this meeting is being recorded. First, Spanish language interpretation is being provided. If everyone could click the world icon on the bottom of your screen when it's available and select Spanish or English. And if you stay in the default channel, you won't be able to hear the conversation. As a reminder about language interpretation, when reading from a script, please speak slower than you normally would to allow time for translation. Fun fact, we tend to read faster than speaking off the top of our heads. We want to find improved ways to include more voices in our process and value any input about those ways we can improve future listening sessions, about the registration, content, anything. I will post a survey link after the meeting, and then I'll stick around after adjournment for questions about the survey. Just a note, this is not a commission or subcommittee meeting. Yeah.
Can we ask the interpreters to give people instructions to join this channel, and then we can
and for everyone, there's a globe at the bottom of your screen now.
They're going to give that in Spanish.
Okay, so go ahead.
Rosie or Victor, can you do that?
Here, sorry, I have to end the interpretation. I thought that Daphne had given the instructions. So one moment.
We need them in Spanish too. I'm sorry for the mishap.
Okay, there we are. Now Rosie and Victor are back on our channel.
Actually, you turn it off, so we were already in the channel. So you need to turn it back on.
Can you give instructions if people don't, if in Spanish, so if people don't know how to join, they know how to go over?
Sí, muy buenas. Este es el intérprete. Bienvenidos para que a esta junta tenemos español disponible. Así que si por favor puede seleccionar el icono de globo donde sale la palabra interpretación, para que así de esa forma puedan seleccionar su canal de preferencia. Similarmente, si están ingresando por medio de un teléfono o una tableta, van a ver 3 puntitos con la palabra More o más. De ahí le va a aparecer un nuevo menú y de ahí de ese menú selecciona su Language Interpretation o interpretación de idiomas y de ahí su canal de preferencia. Si desea la junta en español, por favor seleccione español, o si desea inglés, por favor seleccione inglés. Si tiene algún problema, notifíquenos en el chat. Muchas gracias y que tengan feliz día. Adiós. Okay, back to you.
And for those of you who prefer to be in English, once the interpretation is on, you're going to actually need to select English.
Okay, so everyone click their More button at the bottom of the screen, slide up to Interpretation, and pick the language of your choice. Okay, I'm in the English channel. So the other thing I wanted to talk real quick about is how this isn't a commission meeting. It's also not a subcommittee meeting. And we're not making policy decisions today. The purpose is to provide space to listen to concerns and for staff to answer questions related to the commission's work, and also to hear a presentation about what's gone on with the benefit update project. In the year plus since we've been doing these sessions, we've seen these discussions help improve care and access to important services for OHP. And one of those things is Ehlers-Danlos syndrome. And like, I had a bunch in my head and now they're gone, but maybe Errol can address that. Today, our staff will listen and ask questions. And if they consider recommending changes to the Health Evidence Review Commission, you'll have plenty of time to make comments then. Our presenter today does not want to have a Q&A session with him about the topic. So at this time, I'm going to turn the meeting over to Dr. Smits. And Dr. Smits, go on with the bad self.
Thank you, Daphne. And my name is Ariel Smits. I'm the medical director for the Health Evidence Review Commission. As you can see, there's commission staff on this call, and as Daphne mentioned, there are no commissioners here. This is really we're hoping a a, a place where providers, public, patients, other people can come and ask questions or let us know um, the issues, things, and as Daphne was mentioning, staff have followed up on multiple issues that were brought up at this session, and that has fed into her decisions. So thank you all for coming. We really appreciate you taking time out of your day and hope this was a really productive session.
Great, thanks, Ariel. I'd like to introduce our first and only topic for today outside of our staff presentation. But I'd like to make a quick statement about sensitive discussions. The next topic is applied behavioral analysis, or ABA, for conditions outside of autism treatment. And that might be a sensitive discussion for some. HERC is a policymaking body and doesn't make decisions about care for individuals. And this discussion may be intensely personal for some. In this forum, we tend to discuss subjects in terms that can seem clinical and impersonal, but not every person's experience will fit into the picture that clinical evidence shows. The commission's business is to make the best possible decision for the general population, and then they determine the importance of services by using the HERC's methodology and processes you can find on our website. Any changes resulting from today's discussion would go into effect at a future date after a review by the subcommittee and the commission. This presentation topic, as I mentioned before, will not be open for a forum's Q&A. If the commission takes up the topic, there will be many chances to engage. Today we have Mr. Turtle, Dr. Larson, and somebody's name who escapes me. Apologies.
Lynn Claire.
There's actually been another person added.
Okay.
Apologies, Miranda Drake. And at this time, I'd like to turn it over to them as soon as I can make them a panelist. Dr. Larson.
I was just going to ask if you needed me to do that, but it sounds like you're already on it.
Alter Dong.
So you all need to accept. Yeah, it looks like you're doing it.
I'm looking for Miranda Drake. Do you see that person?
Miranda Drake, if you're here, if your registration name could match, if it doesn't, raise your hand.
Actually, we're Miranda Drake was unable to be here. I'm checking the Q&A. We're looking for Keel Rotarius instead.
Who?
Keel, K-I-E-L.
Oh, okay.
First name.
Thank you. All right. So when you get that notice, please accept, and then you'll be able to unmute yourself. We're going to have 10 minutes for our presentation time, and then 10 more minutes with Dr. Smits and staff. So, Mr. Turtle, take it away.
And Mr. Chiddle, you're muted and your camera's off, just FYI. Mr. Chiddle, if you're just speaking, we can't hear.
Can you hear me? Can you hear me now?
We can hear you now. Yes.
Great. And let me see if I can figure out that camera. So, and thank you for taking the time to talk to us about this issue. So, Back in 2013 and 2014, we, and that when I say we, that also includes Dr. Larson, who has a kindly joined guidelines, symptom services, and some other conditions. And at that time, the commission agreed to add lines both for ABA for autism as well as ABA for self-injurious behavior. Um, since then, the field in Oregon has grown very well. There's been a lot of very good engagement with both OHP and commercial insurers. I believe we have more than 2,000 professionals in Oregon who are licensed by or registered by the state of Oregon to provide ABA therapy, either as BCBAs or the technician supporting them. And what we want to talk about is uh, really the using ABA for purposes other than autism and self-injurious behavior, such as intellectual disability and other developmental disabilities. Strictly speaking, under EPSDT for Medicaid, that would already be a covered service. The question really comes down to a discussion of evidence and helping to sort of communicate and inform CCOs about the level of evidence. Similarly, for commercial insurance, we have a bill in the legislature now, House Bill 2023, that would streamline and sort of set up a process for ABA for intellectual disabilities and other developmental disabilities. But coverage is actually already a legal requirement under Oregon's mental health parity law and other statutes that we have. But again, the question really comes down to sort of discussion and review of the evidence. So I'd like to pass this over to Dr. Larson, and is it Keel also who will be helping us? Please go ahead.
I'm not sure which of us should begin.
Go for it.
Myself, this is, excuse me, I'm Eric Larson. I'm a licensed psychologist in Minnesota and Nebraska, and I direct the Lovaas Institute Midwest. The main point I'll make in my presentation, and I had submitted a couple of white papers that I believe this group has access to. So I can submit them again if you don't.
Yeah, please do send those. We have not had time to review those.
Sure. So I'll just give a quick overview summary. The main point I want to make is that historically, and especially when HERC was evaluating autism treatment, it was really looking at successful treatment of autism itself as a syndrome, and ignored the aspect that 1/3 perhaps of the participants in the studies we were looking at 10 years ago also qualified for diagnosis of intellectual disability. They all had IQs below 70. About 1/3 of the participants in the autism studies had that IQ range. And so we really have an overlapping spectrum. We have children with autism who don't have an IQ below 70 in the autism spectrum. We have persons with intellectual disabilities who don't also have a diagnosis of autism. But then in kind of a Venn diagram, we've got that middle group that both have a diagnosis of autism and an intellectual disability. In the studies that I summarized in my white paper, there are about 2,000 participants, children and adolescents listed in those studies. And many of those studies are not saying they're just that middle group. They're not saying it's only persons with IDD and autism. Many of the studies are just looking at IDD. So at least 1/3 of the participants that you're familiar with from the autism literature also show effective response to applied behavior analysis. And that matches up with the most recent CDC report on the prevalence of autism, finding 37.9% of the autism spectrum also has an IQ score of 70 or below. And I'll just use that as a formal distinction for autism, for IDD. So to me, this really isn't a black or white issue. This is just a broad spectrum of persons who benefit from individualized treatment of specific behavioral challenges. And the behavioral challenges, again, are not meant to be described as a cure, so to speak, for autism, but instead useful treatment service for the kinds of concerns that those individuals have. Persons with IDD deserve person-centered treatment, which means they come seeking help for specific concerns that they have, whether it's very basic self-care needs or basic needs for accessing the community, needs to manage their tendencies to bolt or wander in the community, resulting in the high risk of death, or whether it's simple quality of life goals. And the research in applied behavior analysis has shown high levels of effectiveness in meeting all these basic behavioral needs of that population. So I'll stop there. I'm happy to take questions or yield on to the next speaker.
I'm sorry to jump in. I just had a question for you, Dr. Larson. So, in the studies, were there people with just intellectual disabilities who did not have autism, or were they all that overlap population that had autism and IDD?
The group of studies that we looked at 10 years ago, again, were identified as studies of treatment of autism. So within that group, you have about a third that are scoring below a 70 on IQ.
Right, but are there
take
studies that
then-
just look at IDD
Yep,
in
and
people
then-
without autism?
Yes, so then in the paper that I'll resubmit to you folks, there's numerous studies where the word autism isn't even in the title of the study. It's just developmental disability, perhaps, or intellectual disability. And in many cases, it's a large group. It's 100, 200 participants that are summarized, sometimes in a meta-analysis or sometimes just in an overall summary of a large number of smaller focused treatment studies. And again, they're not described, maybe they're in the details when it lists comorbid conditions. It may also list autism for some of them, but the focus was much more on developmental disabilities and not on autism.
Okay, thank you.
My name's Kyle. I'm the Public Policy Committee Chair for the Oregon Association for Behavior Analysis. I'd like to just jump in right here to support Dr. Larson's point. There are many studies currently, and within the last 20 years supporting just generally IDD and applied behavior analysis as a treatment for it. We've prepared, the Oregon Association for Behavior Analysis has prepared maybe like a lit review of about 40 articles. And these were just the things that we could get together over the weekend that we'd like to submit to for this. Many of the articles that we found come from journals such as Behavioral Approaches to Assessment and Early Intervention for Severe Problem Behavior in Intellectual and Developmental Disabilities. So outside of the typical literature of applied behavior analysis. And the articles that we've submitted or that we'd like to submit include domains of Down syndrome, IDD, but also traumatic brain injury. An ABA is used for many things outside of those already, including organizational behavior management for employees, sports medicine, um, really many different areas of teaching. Some of the founders of our field created technologies and treatments for that are still used today in behavioral pediatrics, such as toilet training or um, sleep deprivation or children going to sleep problems, I guess I should say. So if we can, we'd like to submit that as well alongside Dr. Larson.
Great. Do you, Daphne, do you mind dropping in the chat the HERC.info? Just so that,
Absolutely.
thank you.
And I did want to say I just scoured herc.info in my email and I didn't see anything. But I will keep an eye out.
Regarding Dr. Larson's materials, he sent them to me. I submitted them to the House Committee on Behavioral Health, not to you. So I think that's the confusion.
Yeah, if you don't mind, either Dr. Larson or Mr. Chadal, if you could just send them to herc.info. That it just popped into the
Nope,
the
I sent it to the wrong people.
I got it.
I'm doing it now. You got it. Oh, because you're a panelist. Gotcha.
Great.
Yeah, that's usually the best contact address. It will always come to someone at the HERC team, and we can put it out into the appropriate person or place.
And more people monitor that.
If I could just add very briefly, Kyle was doing and Dr. Larson were both talking about sort of broader applications. I was at a lecture at MIT several years ago where they were presented a study on use of ABA methods to teach surgical skills to medical students. They found it to be more effective than lecture and demonstration because it's essentially about building habits for drilling and cutting precisely. Just they found ABA methodology to be more effective.
It's time for the presentation. We can now enter into a Q&A with Ariel. If you have questions you'd like to ask her directly, or Ariel, if you have questions.
No, I'm looking forward to your materials. We'll take a look at them, and I'm sure you realize we're all really busy with the Benefit Upstate project, but we'll take time and take a look at them. But it sounds like there's sort of, are you looking at this for like a really broad range of conditions? Like I heard Kyle talking about toilet training, sleep training, those kinds of things, or are you more looking really at looking at the HERC, looking at this for intellectual and developmental disabilities or a combination?
So there's a House bill under consideration which was looking specifically at intellectual disability and other developmental disabilities. As I think so I think that would be like the baseline ask. In more, and I think just given the way HERC works, I think that's probably where I would point you to first. There are certainly a wide variety of other kinds of applications beyond that. Um, I mean, including things like chemical dependency and other kinds of things, but I would suggest you start with intellectual disability and other developmental disabilities because it's a more natural extension from the autism and self-injurious behavior that you have already done.
Okay, great. Thank you for that. Yeah, any questions for me? I feel like I need to review all your background information before I could really kind of dig in.
One of the questions that that you're going to need to consider is really about standards of evidence. This is something we discussed at length a dozen years ago when we were looking at this, and I mean, I have done professional work in the pharmaceutical industry, which will produce, spend $1 billion on large-scale RCTs, to sort of advance and demonstrate drugs. Nobody's going to do that here. And I think there's a question of, I would suggest, as part of this, you may need to sort of go back and revisit, what are the standards of evidence? Where should the bar be set for things like this? And I don't have a clear-cut answer. I think Dr. Larson and Kyle will probably be able to give you sort of better input on that. And we can certainly come back with more materials relating to those, what appropriate standards of evidence for this kind of thing. But I think that's going to be a significant part of the question.
Thanks.
All right. This is Dr. Larson again. I could jump in on that if it's okay. Back when we were first looking at treatment of autism, we were discussing the difference between group trials or single case research designs. And the single case research designs were looked at as sort of second level quality. But I think even more so today, in the context of the neurodiverse movement and compassionate care, we've really recognized that person-centered care is individualized, and the ABA research in the form of single case studies is more relevant to that kind of compassionate approach to treat individualized treatment than are the between group studies, which are much more of a sledgehammer analysis of how many kids can lose their diagnosis of autism, when that's not really the concern of many of folks who are living with neurodiversity today. They're much more concerned about a very specific behavioral challenge or skill challenge they have, and they're very concerned about being participants in defining the objectives of treatment. The ABA single case studies then still allow for an experimental validation. It's not just a philosophical analysis of how happy the person is. It's still identifying with the cooperation of the person and their caretakers what it is that they're really seeking in treatment, defining that in an objective manner, and then evaluating using single case experimental techniques whether that procedure that was then offered to them really was effective in meeting their goals. So the paper that I submitted is really summarizing many different single case studies with individual participants, rather than trying to lump them all into a single group that's more homogeneous.
Great, thank you. Thank you for all the clarifications. I see that we have like less than a minute left, so I want to thank you all for bringing this up. I look forward to looking into your materials, and we'll get back to you as needed. So thank you for taking the time.
Thank you.
Thank you.
Thanks, everyone. At this point, I'd like to turn it over to our director, Jason Gingrich, who's going to give us a presentation about the benefit update project. Jessica, do you want to get the slides ready?
I sure can.
Hey, welcome, everyone. I see a number of people here watching. Glad to have you all here today. I know some of you I see some names that are familiar from other settings. And just as we discuss, the purpose of this setting is designed to be more focused around members who themselves use the Oregon Health Plan. So let's make sure to make space for their concerns and questions to be addressed. We'll run this a little more informally than we ran the last one. So again, my name is Jason Gingrich. You have pronouns. I'm the director of the Health Evidence Review Commission. I'm not a clinician. You see the names there of the other members of our team who you see on the camera. And let's go on. So what we're going to talk about today is the Benefit Updates Project. For those of you who haven't heard, we'll be going over this project. Why is it happening? How will it affect coverage? We'll be looking at the prioritized list, which is our work with the Health Evidence Review Commission, and what will replace it in 2027. How will decisions be made, both in the transition process and after 2027, and then have time for engagement, how to get involved or get concerns addressed. And I should say that what I'm presenting is based on what I know today. The legislature is in session, and things may go a different direction there. There's also federal changes happening, and we don't know how those will affect. But this is our plan at the Oregon Health Authority. So with those comments, I'll go ahead and dive in. And from here forward, let's go ahead and, if you want to ask a question, maybe jot it down if you have a piece of paper or in the Q&A, and then we can take them at the end. That way we can address the questions, and because I may get to the thing you're asking about in a later slide. So the prioritized list has existed for 30 years. If you could go back, Jessica. Can you go to the previous slide, please? One forward. There we go. And I won't go into the detailed history of the prioritized list in this setting. There's more in other presentations if you look at our most recent HERC meetings on our meetings page on our website, and I've given that in other settings. But it's the way we've managed the Oregon Health Plan benefits and controlled cost and ensured safe and effective services for the past 30 years. And in 2022, the federal government informed us they are ending the legal authority Oregon had or has today to use the prioritized list to limit benefits. So let's go on next slide. So I want to give the bottom line up front, because when I talk about ending something, people can, worry that they're going to lose something. And from a member perspective, we are not expecting any changes in eligibility, and we are not expecting any benefit reductions as a part of this project. So nothing to fear, nothing's going away as far as benefits, the benefits you get in the Oregon Health Plan as a part of this project. There are some new concepts that will be used. Some new services will be paid for. So that's the good news. There may be services that have been denied in the past that would get paid for. And we'll get into some examples of those. And there's also a new appeal right. For those of you who are not enrolled in a coordinated care organization, if you have something called fee for service or open card, there will be a new member-focused appeals process launched as a part of this project. Next slide. Again, some new services will be covered. None are going away. HERC, the plan is for HERC to continue to determine the medical necessity policy, much like it does today. HERC will decide, however, that some services are not medically necessary, and these won't be covered. To get some services, just as is the case today, members must meet medical necessity criteria or have tried other treatments that haven't worked. So those things that exist today will continue to exist. It's just there will be some newly available services. Go ahead. So what we review at HERC, just a brief overview, we make our goal with the Health Evidence Review Commission is to make sure that Medicaid covered treatments and equipment are safe and proven to work. These policies are shown on what we know as the prioritized list. It includes largely medical procedures, lab tests, imaging, so x-rays, MRIs, CT scans, PET scans, acupuncture, physical and behavioral health therapy, dental service. I didn't mention chiropractic services. There are a number of other services, chemical dependency services, substance use disorder services. There are some services that HERC doesn't review, at least not very often. Medical equipment and supplies are usually not something we review at HERC, although there are some exceptions. Medical transportation, anesthesia, and inpatient hospital services, prescription drugs, services for social determinants of health like housing, income, education. So that's kind of the universe of things we talk about at HERC. So mostly focused on things that happen in a doctor's office or outpatient hospital setting, or sometimes it's a surgery or a device that's put in a hospital setting. And dental. Go ahead. Next slide. So HERC, again, you see the description of our kind of our mission there. We use medical evidence, expertise, and public input to decide which services to cover on the Oregon Health Plan. The prioritized list is our current way of organizing the benefits and expressing those policies, putting them in writing. The guideline notes describe the detailed coverage requirements for some services. So sometimes you have to meet certain conditions in order to get certain services. There are other reasons requests get denied beyond the prioritized list. A member might not be eligible. There may be a lot of different reasons. There may be some benefit limitations. There may be administrative rules or benefit limits that come into play. But the prioritized list is a big part of managing our benefit for those areas I discussed on the last slide. And in 2027, our plan is for the list to be replaced by, quote, clinical coverage policies. Much of this will be the same policy by a different name, just necessary for our legal reasons to call it a different name and to make it make sense. And honestly, to align with the way other health plans do business or other states. And again, some new services will be paid for beginning in 2027. Next slide. Can we get the next slide, Jessica?
I'm trying. There's a delay.
Okay. Must be internet
Oh,
slowness.
sorry.
Oh, no, we got.
Format change. Okay. Clinical coverage policies. There we go. Concepts.
Okay. So there's some concepts that we don't often run into in daily life. You run into them if you experience them. I'm going to try to oversimplify them a little bit for the purposes of today. Those of you who are legal or doing this professionally will know that it's much more complex than this, but I'm going to try to hit the high level description. So one concept is the benefit limit. Is this the kind of service the Oregon Health Plan would cover if it would help someone's health? So again, definitely in doctor services, therapy services, acupuncture, chiropractic, those things. Other things outside this, we don't buy people clothing, we don't buy people food, we don't buy people cars, we don't, jewelry. Those are things that are outside the benefit package. There are also some things that are medical that are outside the benefit package. Like glasses, like these ones I'm wearing, are not an Oregon Health Plan benefit unless you have certain diseases of the eye. There are also some dental services that are safe and are effective, and OHP does not cover because of budget limitations. There are some exceptions to what I just said. There are things called flex services in lieu of services, health-related social needs, that do meet some of those broader needs people have of shelter and food. But that's not part of what we address at HERC. Those are addressed in other places. So I'm kind of telling you we have a narrow universe, but then there's somebody else who works on those things, and those programs have their own rules. The second concept, so that's benefit limit. I think of it as like a circle with a hard line around the outside. If it's outside of that line, it's not going to be covered, no matter how badly you need it. Medically necessary and appropriate is more of a judgment call. And it is applied at two levels. The first is the policy level, and that's what we do with the Health Evidence Review Commission. Is the service safe? Is it effective? Does it benefit a person for health reasons? And, sometimes we even get into which conditions does it benefit for health reasons, and what treatments do they have to try first before they should try this one. The second is the individual person level, and that is a level of review that is done at the health plan when there's an individual request to make sure that it's the right service for the right person based on their condition. So that's more of like applying it to somebody's individual case. And that's what Daphne said at the beginning. We don't do that at HERC. So we try to make the general rules, and then the coordinated care organizations and our medical staff here at the Oregon Health Authority make sure to apply those policies to make sure that the right services are paid for. So today we are expressing some combination of both of those on the prioritized list. In 2027, the medically necessary and appropriate will be expressed in the HERC clinical coverage policies. The benefit limits, that hard line around the outside, will become, be more taken care of elsewhere, although HERC will have some ability to influence that. Next slide. All right, so medical necessity. This is an interesting term. It's used in healthcare in the United States. It's not defined in federal law. Each state can define it. However, Medicaid can only pay for medically necessary services. So it's a little bit of a strange thing. You can only pay for it if it's medically necessary, but states, you decide what's medically necessary. For the Oregon Health Plan, our definition of medically necessary and also medically appropriate, which is a part of that, are defined in state law, and you see the reference to the administrative rule, which you can Google if you so desire, and it's a long list of definitions, and that's one of those are two of the definitions. There's also one for dentally appropriate. Our HERC developed code pairs and criteria, which will be part of those clinical coverage policies in the future and are part of the prioritized list today, will define by policy, what is medically necessary for the Oregon Health Plan. Again, this is that policy level of the medically necessary. And then the agency rules and policies determine the benefit limits. So go ahead, next slide. Our definition in state law, I didn't put the whole thing in here because it's long and complicated, but it includes services for prevention and early detection to prevent illness or impairment, for the diagnosis and treatment of acute illnesses. That means, like things that are happening right now, like a broken bone or a cold or a flu, and including emergencies. Diagnosis and treatment of chronic illnesses, so longer-term conditions like diabetes or intellectual disability or autism, which we heard about a moment ago, or services for those conditions to prevent complications, services to improve functioning and independence in activities of daily living, and for helping children achieve age-appropriate development. And again, those are all in that rule. Next slide. Some services that are not medically necessary are things that are ineffective, unproven, or harmful. And so, why would we be providing those services? Sometimes services are more costly than an equally effective and readily available alternative. Sometimes they're experimental or investigational. We just don't know whether they work. Sometimes they are cosmetic or principally to improve appearance, and those aren't the kind of services we cover on the Oregon Health Plan. Or services that are solely for the preference or convenience of the member or provider. Next slide. So I want to go through some examples, and this is a little bit of a busy slide, so please just follow me through. I'll get to all the bullets. And I'll talk about how each one will be treated today, or also how we expect them to be treated in 2027. So primary care visit, you go to your doctor for managing your diabetes or for a cold or a cough or whatever reason you may have to get a preventive checkup. Those things are covered today, will be covered tomorrow. Subject to the same rules, nothing's changing there. Setting a broken bone, stitches, blood pressure management, all these things are covered services today. You may get prescribed a medication. Sometimes those have some limits on them, but more often they're just covered. And again, same today, same in 2027. Acupuncture for tension headaches. This is an example of one of those services today that is below what we call the funding line on the prioritized list. HERC decided at its January meeting that that is a medically necessary service, and it's not covered today, but they recommended, or they added coverage for that effective January 2027. Back surgery, something I had a couple years ago, and that requires prior authorization. You have to meet certain criteria. You have to have like numbness or weakness in your limb related to your back. And those criteria exist today. They will continue to exist in 2027. They'll just be called different things, but the same policy is what we expect to be in place. Eyeglasses, many root canals for adults. Those are outside the benefit package today. We know that those are safe and effective services. They're just not part of the Oregon Health Plan benefit. The legislature has not provided funds for those. So that's something that's not changing, although it's something we often hear from our members that is very much needed. Limits on medical equipment. So there are a lot of rules around wheelchairs and walkers and equipment you may need for home health. Most of those are not on the prioritized list. There are a few exceptions for things like continuous glucose monitors, a few other pieces of equipment, but for the most part, those are in rule and are not going to change. The only thing that would change is if one were prescribed for a condition that's currently unfunded today, it could be denied just because it's for a unfunded condition. And some of those conditions include fibromyalgia, some of the chronic pain conditions. There are many others that I don't think a lot of these need medical equipment, but that would be something that would change, that they would be considered, but you'd still have to meet the other limits on those equipment that are in rule. And then there's preferred brand medications. If your doctor prescribes, the brand new medication, they may ask you to try a generic first. No change expected for that. And here we get into that for appearance only liposuction, generally not covered today. In 2027, that will be treated as not medically necessary because it's principally for the purposes of appearance. So again, the same policy, although the message on the denial might be different. And then steroid injections for back pain. This is a commonly offered service in Oregon. It's a medical service. It's not covered today on the prioritized list. And in 2027, we expect the policy to say that it's not medically necessary. So still, it would be denied. Again, just a little change in language. I'm going to pause there. Are there questions at this point, especially about any of these examples? Go ahead and raise your hand and we can unmute you, or you could put it in the Q&A. I see Lisa has a question. I'm just going to enable Lisa first.
Yeah, hi, this is Lisa Pearson. So I have a question about the steroid injections for back pain. So as somebody who is currently awaiting surgery for a back issue, I have been told by my primary care to go to pain management and get steroid injections until I can get surgery. Surgery has to be scheduled at OHSU. There's a very long wait for that. So I'm not quite sure what the disconnect is between payment for services and my primary care's office recommending this as medically necessary at this point.
Yeah, and that is something that the Health Evidence Review Commission reviewed a number of years ago and found that the evidence did not demonstrate that those were effective, that the benefits outweighed the risks associated with those steroid injections. And I know it's frustrating, especially when there's a shortage and a delay to get surgery. That is something that we look at periodically. And if there are new medical studies and if you want us to take a check, we can do that. So that's the status of them. That's when HERC has to make a difficult decision about a service that people want and people believe works. Many people do believe those work. However, the medical evidence doesn't really support that based on the last review we did.
So I'd just like to ask that you could relay that information to Samaritan Internal Medicine in Corvallis. I happen to agree with you that those probably are not effective, but they will not let me stay on prednisone until my surgery. And the only other option they have offered me, other than steroid injections, is oxycodone, which I would prefer not to be on. So, I mean, if your choices are you're not going to get your prednisone if you don't go to pain management, or you're going to, I mean, they ask, are you taking your oxy every 8 hours as prescribed? I'm like, no, that seems like a really bad idea too. So anyway, that's my input.
Yeah, those are difficult situations. Those, we operate at the policy level. If you have a concern about the care you're getting, I'd encourage you to contact your coordinated care organization if you have one, or our OHA ombuds team. And if, Daphne, if you could put that contact information into the chat. All right, I'm going to the next person, Paul.
Hi, can you hear me okay?
Yes.
Great, thank you. So I guess I have sort of comments or questions about the words not medically necessary and also experimental or investigational. So with a commercial insurance plan, if my physician comes back and says, hey, that's not medically necessary, there's an appeal process where I can say, hey, actually, here's why my doctor says it is medically necessary for me, and we do that internal appeal. And then if we still are deadlocked, the insurance commissioner recruits an independent medical review organization with a sort of qualified expert in the field to make a decision. So we don't have to litigate that. It just gets a medical expertise to sort of revisit that. I think one of I guess the concerns that I have is if you have a blanket statement in like a policy document saying not medically necessary, how does that bring in the question of like an individualized determination?
Mhm.
And is it perhaps what you're really saying is this is experimental or investigational?
Yeah. Ariel, I don't know. You participate more in those conversations than I do. Is there an important distinction between experimental and investigational as you review cases in MMC?
I'm trying to think of the sort of Paul's bigger question. So there is an appeals process. So if your doctor feels that something's medically necessary and it's not covered under OHP, or you get a denial that it's not medically necessary, there is an appeals process, just like with private insurance. Um, and many things, something can be not medically necessary, but not necessarily experimental. Um, Private insurance would probably use more experimental and investigational as they're not medically necessary reason. And that is generally what um, I don't know if there's a specific difference. You could have
If,
many studies that aren't conclusive.
so if I could maybe like sort of elaborate on my question, and this might be a rhetorical question for you to think about, but um, if you put in as a policy statement saying, hey, we're not covering this because this is not medically necessary, is there any way, shape, or form where it can appeal past that? Or is everybody just going to say, hey, HERC, this is not medically necessary, that's the end of the discussion?
Yeah.
Um,
Yeah, I can answer that, Paul. So just as is the case today, if a service is denied because of the prioritized list today or in 2027 because of the clinical coverage policies that say it's not medically necessary, there is an appeal, and the information submitted without appeal is reviewed, and coordinated care organizations or the medical management committee that helps with our fee-for-service population will review that. And if they find, that it doesn't match the HERC policy, they are in good standing in denying that care. If they believe there's some reason to make an exception, they have the authority and judgment to do that, but it's ultimately the plan's decision. If that appeal does not go away the way the member or provider wants, there's a hearings process, and that gets to be a legal process that I don't know all the ins and outs of. But the intent is in general that the HERC policies can be relied on by plans to deny services, but that there is an appeal and there is also the opportunity, because human beings are complex and there's no way our policy can encompass every person's needs, that CCOs can and do. We are aware make exceptions for individual cases.
I'm going to encourage you to revisit the idea of independent medical review for Medicaid, because that would, I think, be much better for patients than litigation with the administrative law judge.
Yeah, and so, here at the Health Evidence Review, that would require a legal change, I believe, and I think there have been bills introduced about that. Our job at HERC is to make the policy, and the Medicaid program does, and the CCOs implement that policy according to the law and their contracts. I see Bridget has her hand up.
Jason, I'd like to address something in the Q&A.
Okay.
Josh would like someone to share the medical necessity rules. Having Googled it, didn't find that. Can we put that in chat? I don't have access to it.
Yeah, it's the Oregon Administrative Rule 410-120-0000. And you can find it at the Secretary of State's website. And if you email us at herc.info, I can send you a better link after the meeting.
Okay, Josh, I'll send you that address directly. And then Joanne is asking about having an info form for the appeal. And I assume that would need to go through the CCO or a fee-for-service situation.
Yeah, you need to contact your coordinated care organization, or if you're on the fee-for-service program, our member services department.
Yeah, exactly. Again, we're a policy shop making global decisions, and yeah, absolutely. So,
and we will post the slides on our website after the call today. If you need help finding the link, please email us at the address that was put in the chat a few minutes ago.
Okay.
Oh, and Josh, I noticed the OAR you had in your Q&A. It's 410.120, not 121. That may be why you had difficulty finding it. Okay, Bridget, I'll take your question next since Lisa already asked a question.
Okay. Can everyone hear me okay? Sorry.
Yes.
Hi, Bridget.
Oh, sorry. Okay. Sorry, I can't see like the mute, so thanks for doing this. I think this is a quick question. I was curious, and it sounds like it's a little bit similar to the question that was just asked, but under clinical coverage guidelines, would there be a specific entry where a provider would use like a code or a coverage guideline, something like that, to signal, hey, I've reviewed medical appropriateness and medical necessity and while it may not be medically necessary on a population level for this specific person, I think it is, and so I'm going to use this guideline note? Or how would they use the new clinical coverage guidelines to suggest? Is it just that you get the prior authorization back that says no, and then you do that paperwork? Does that question make sense?
Yeah, you're asking about operations. And again, our job at HERC is to make the clinical policy. And those operations are governed by CCO policies and administrative rules. And I'm not as knowledgeable about those as I wish I were. But I know there are ways to, the policies will be public and they can be referenced if often plans will have one-on-one conversations with providers where they can talk about those kinds of things, or they can submit documents in support of their appeal. And sometimes that can be done in advance as a part of the prior authorization request. But again, the procedures may be a little different for each coordinated care organization.
Okay, thank you, Jason. So there won't, in clinical coverage guidelines, there's not going to be anything in there about, so that won't be included in there. That's going to be up to the CCO.
Yeah, that's operations. So our is service X appropriate and medically necessary for condition Y? Yes, no, or, if this is also true, like we'll make the policy, but the implementation that's an administrative process that we don't get into all the details of in our work at the HERC. Although it is a very important part of operations. And I do see Lisa has a follow-up about some difficulties, dispute with the CCO, and the ombuds is the appropriate place to take those kinds of questions.
Jason, I thought I heard a little something different in Bridget's request. She was talking about codes or at least a code, and we will be doing code pairings still.
Yeah.
Is that my understanding? Okay. But
Yeah.
I think she
Yeah,
said some
so
universal code and that's not a thing.
yeah, the medical codes are, determined by the federal government, and
Right.
we make rules about them. And that's one of the ways we express the clinical coverage policy is by saying, epidural steroids for back pain, those codes don't match. And so that's not medically necessary. Or there's a guideline note for back surgery. You can have it if you meet these criteria and the codes match. And so those are different ways of expressing our clinical coverage policy. But again, the other part of the question was about individual situations that don't fit the mold, and we recognize that happens. And that's why there's those appeals process and the request processes that allow you to submit additional information. All right. I don't see any other hands up for the moment. Let's go ahead and go to the next slide. So this is a graph for those of you who are more analytical. It's a way of understanding, how the benefit is changing. So currently with the prioritized list, it's a little muddy which of the two shades of blue the services that are not covered are. They're not part of the benefit. They're not medically necessary, not covered. It's all kind of mixed together, and the denial notices will reference the prioritized list in many cases. In this project, we're going to separate those. So there's two questions. The first one you see at the left there, is the service in the OHP benefit package? And just to make a, kind of a ridiculous example, a diamond ring is probably not in the OHP benefit package. So that goes into that bottom light blue, and it's not going to be covered. By the same token, eyeglasses, not in the benefit package. The second question you ask if it is in the benefit package, so let's go to our back surgery. Is it in the benefit package? Yes. So it's in the top section of the graph. And is it medically necessary and dentally appropriate? Sorry, not medically appropriate, not dentally in this case. It is under certain circumstances. If so, it will be covered. You're in the white square there. And then if it is more like the epidural steroid injections, which we talked about earlier, it is a covered service. It's a medical procedure that's done by a physician, but it's not medically necessary because it's not proven to be effective. So that's in that darker blue, not covered, not medically necessary quadrant. Just give people a moment to ask if there are any questions or comments about that little diagram. Okay, next slide.
Oh, we do have a hand raised.
Oh, okay, Bridget. No, looks like she took her hand down. Next slide. Oh, no, it's up again. Can you unmute? Oh, I have to allow you to speak.
I'm sorry, there was a little bit of a delay on the unmute. I think this is a pretty quick question. So under this framework, under moving from how we do comorbidity analysis now, under the new clinical coverage guidelines, am I right in understanding that the guidelines will just include under each service all of the things to consider, and that's how we won't have comorbidity analysis anymore because there's not a line? everything's just going to be housed within the guideline itself. Is that right?
Yeah, so what Bridget's referring to is known as the comorbidity rule or the comorbid rule. And that's a rule that says, like, let's take that acupuncture for tension headaches example. Acupuncture for tension headaches is in the unfunded of the prior region of the prioritized list, and it's not covered. But there's a rule that says if treating that tension headache would help a funded condition, and I'm not going to speculate as to what that would be, some other condition that the person has, then it can be and should be and must be covered. That just won't be necessary anymore because there won't be an unfunded region. And that's why HERC decided, acupuncture for tension headaches, safe, effective, medically necessary. It will be covered on its own merits, regardless of what other conditions it may help. In other cases, like the back surgery, again, there will be criteria, and it could say we will cover, allergy shots, for example, or another currently unfunded service, only if you also have this other condition. And so it'll be incorporated into those other conditions. And again, because HERC is not perfect and all-knowing, we think our policy is good, but it just can't meet everybody's individual needs. That's what that exception and appeals process is for. And so the comorbidity rule will go away, but people will still have the ability to make their cases that an exception needs to be made. Okay, next slide. Here's how to stay informed. First of all, I'd like to, Jessica, if you could open that HERC work plan and bring it up on the screen. We've published this. There are thousands of conditions that we'll be reviewing as a part of this project that are in the unfunded region and really deciding, are they in the benefit package? Are they medically necessary? How are we going to make the clinical coverage policies for this condition or that?
Jason, are you able to see the webpage, or are you still seeing the
No, we're seeing the slides.
Okay. One moment.
And so we've put this work plan up. There's a lot of information there. It is searchable. You can use that search box to search for a condition, although, conditions can have multiple names. So I could encourage you to page through it if you're looking for a certain thing. But it shows the status. You can see there, the first one, ophthalmology diseases. We had hoped to address those in January. We didn't get time, so we'll bring that to our March 20th meeting. On the other hand, if you scroll down to the uncovered breast surgeries, not that far down. It's up towards the top, actually, Jessica. There. Those were approved as presented by HERC, except with one exception. You can see the exception listed there. You can go to our public meetings page, and you can find those meeting materials, and actually the minutes are now posted as well, and you can see exactly what was decided for those. So that's a way to check on the status of a topic of interest. It's a tremendous amount of work. Ariel, Dr. Smith has done a tremendous amount of work presenting a number of conditions, and we're trying to get those materials out there as soon as possible so people have a chance to absorb them and go through them and find potential problems. Even for things that have already been decided, there's a possibility somebody will think of something that we didn't think of in our process. That's why we take public testimony. That's why we do this in public. So we would appreciate hearing from you if there's a concern that HERC missed an important service. That said, the default, as you may recall, many of the services that are in the unfunded region, all you really need is a doctor's visit to be checked to see if something more serious is going on, or to get management self-care instructions, or say a common medication. Those are covered today. They will be continued to be covered in the future. So a lot of the conditions we're finding just fit into that group of things that those standard group of services are sufficient for. a lot of these other things, they're the ones that are more complicated and they're listed here. Any questions about the work plan or comments? Okay, let's switch back to the slides.
I would make one note about the website you're showing, if you want to scroll up, Jessica. As she's scrolling up, I just want to mention it's searchable by the meeting date. You can click on that and decide what date you want to look for, and the comment deadline is on there too. So if you're looking at a topic and you want to give a comment, you can find that out quickly. And that's all for me.
And if you find it confusing, email us. We're pretty responsive. We try to get back to most people within a day. Sometimes it takes a little longer than that, but we want to be responsive. There's a lot of information. There's a lot of questions you might have. That HERC.info is your best source. Daphne also put the how to get involved page in the chat, and that includes more direction. If you want to come and testify at one of our public meetings or submit written comment, you'll find the instructions to do that there. You can also submit a topic and say, hey, you haven't looked at epidural steroid injections or whatever else, and say, we'd like you to take a look, and we have a process there for evaluating those requests.
We do have a question in the Q&A from Antoinette Awachi. She says, do you want to read it, Jason, or you want me to read it aloud?
Go ahead.
This is not so much of a question, but a clarification on what happens when a benefit is denied on the commercial side if it's determined the benefit is not medically necessary. The member can appeal internally, and if the appeal is denied and meets the criteria for external review, then an independent review organization will be assigned by the Division of Financial Regulation to do so. If the IRO makes the final determination at that time, and it is binding on both parties. All appeal processes are described in the member handbook. Just wanted to provide that clarification. Thanks.
Thank you. And thank you, Antoinette. And just for everybody, that's commercial insurance. If you have insurance through the marketplace or through your employer, and it is a state regulated insurance, which is true usually for smaller employers, then those are the rules that would be followed. There are some other plans that are regulated at the federal level, and those aren't subject to state regulations. So it really, what your rights are can really depend on which plan you have. For the Oregon Health Plan, we don't have independent review organizations at this time. Although, as Paul said, there's been some move an interest in having them.
And then Lauren Sant gave us a compliment saying you have a lot of work to do in the next 2 years. We do and do, but she says, keep up the great work.
Oh, that's so nice, Lauren.
Thank you.
Appreciate it. Appreciate your engagement. And again, there is just so much to go through. And if we miss something, if there's something we need to consider, that's why we're doing this meeting today. That's why we're having another one next month. And all of our public meetings and our email address are there. So we want to have you involved as much as you want to be. Hopefully much of this is just seamless and happens and makes things better for members of the Oregon Health Plan. But behind the scenes, we have a lot of work. And in those places where it affects members and members need specific services looked at in more depth, we want to hear from you.
Absolutely. So, any more questions from anyone? Great. Well, thank you for the thoughtful and thought-provoking discussion we've had today. Your public comments, as Jason was saying, are always welcome at our Value-Based Benefits Subcommittee, the Health Evidence Review Commission, the Evidence-Based Guidelines Subcommittee, and any of our advisory panels. I posted the link on how to get involved just a moment ago. To make public comments, I'm going to post that form we use to make it a little bit easier for you. We also would be very grateful to you if you would complete a survey about today's event. Helps us plan and facilitate better events in the future. I'm going to put that right in the chat. And it really should take not much longer than 5 minutes to complete. And I'll stick around in case you have any questions. If you do, raise your hand or put it in the Q&A. And that concludes the meeting for today. Thank you. Thanks everyone for coming. Appreciate you.
Yes, thank you. Thank you, interpreters.
Thank you so much, Rosie and Victor.
Looks like people are leaving.
Okay.
All right, we have stopped interpretation. And it looks like we've just got some things in the Q&A, but I think we talked through those. So
Yeah. Does anyone want to debrief? Does anyone have time for that?
I think it's all right. We've still got a couple members of the public on.
Yeah,
Let's go
I
ahead
meant
and drop
going
and
to a Teams meeting.
we can debrief on our staff call.
Okay.
Thank you all.
Bye-bye.